jump in with any questions at any point. Like Glenn said, I'm going to talk for the next little bit on this topic here, building a personalized approach to treating men with advanced prostate cancer. This is based on a talk I gave last year. I had the opportunity to speak at the Prostate Cancer Support Group Conference in Vancouver. And so this talk will share quite a few similarities to that, kind of reiterating some of these topics of personalized genomics and medicine in cancer, how to go about looking at DNA in very small amounts in the blood, what biomarkers are, etc. And then at the end, hopefully, if there's time, I can talk about a few anecdotes of what our lab is working on right now, and some interesting research trips that we have planned in the next year or two. Okay, just to start. So as I'm sure many of you know, most cells in the body contain DNA in some capacity. This DNA kind of acts as the ingredient book for all actions in the cell, anything that you need to create to drive any process like cell growth, proliferation, response to environmental stimulus, all of that, or most of that, comes from DNA as a base. Now, by and large, most of these cells use their DNA perfectly fine day to day. Changes can arise. The word we use for change to DNA is mutation. Mutations can be benign and have no effect, or they can have some limiting effect on the cell. By and large, these are mostly cleared. The cell has very advanced and redundant processes in place to repair any mutations and changes that occur. So by and large, the cells can weather this. Every now and then, unfortunately, there are some mutations that kind of stick in the cell. They don't get fixed and they're passed on through additional cell lines of proliferation. And over time, if these mutations have an influence on how fast cells grow or how often they proliferate, they can drive this idea of uncontrolled proliferation where they're constantly replicating and reproducing when they should not be. If the body can't respond as limited, you have this explosion of cell growth that we then classify on a simple level as cancer. Now, these DNA mutations, these changes can come from many different sources. It's important to know. Some of them are hereditary, that are passed on through ancestral lineages. Some of them are from exposure to chemicals or carcinogens in the environment, like the radiation present in UV light or the chemicals in, say, tobacco smoke. That's why smoking is greatly associated with increased risk of lung and bladder cancer. And even the day-to-day process of the cell, there's so much rewriting of DNA going on that errors can arise. And sometimes these stick as well. One thing that's important to denote is the difference in two major classifications of mutations, germline and somatic. Germline mutations are inherited. These are present in every single cell in the body that carries DNA. And when you have children, they'll be passed on to them as well. Somatic mutations acquire later in life due to some kind of stimulus, like the ones I mentioned before. They are generally isolated to the region in which the mutation first occurred, and only the cells that grow from that original cell that acquired the mutation will have it. An example of this is melanoma, which is a cancer very much associated with mutational change due to skin cells and their proximity to damaging UV light and the mutations they cause. But again, these mutations are isolated to the cancer cells themselves. You cannot pass them on. So important to denote this distinction. Germline mutations are very important in prostate cancer. There's a lot of mutations that are discussed right now because they increase the risk of patients with or people with them developing prostate cancer later in life. And this can be as much as a twofold risk or more, and also increase the risk of early onset cancers, which come with their own host of challenges. But it's important to delineate the difference between these two. So on mutations in prostate cancer, it's important as well to realize that every patient's cancer is unique. Even within, like, say, prostate cancer or advanced prostate cancer, no two patients' cancers are going to be absolutely identical from a genomic mutation point of view. There will be some similarities, and I'm sure you've heard of different genes that are like often talked about in the literature these days. TP53 is not just unique to prostate cancer, but is ubiquitously mutated across a host of different cancers. It's known as the guardian of the genome, and its role as a powerful suppressor of tumor activity is very well characterized. And when it's lost, it can be a very early trigger to cancer development. As sure we also know BRCA1 and BRCA2, the BRCA genes, first characterized in breast cancer. We now know they play a role in ovarian cancer and prostate cancer as well. And those are just some that are observed to be disrupted in many different cases, but there are so many other alterations that are unique to each individual patient. And when this idea was first characterized years and years ago, it gave birth to the idea of personalized medicine. The concept that if you could design drugs to exploit specific genomic alterations in each different cancer, you can develop this armamentarium of treatments to respond to all different cases you see. This is kind of what this flowchart here shows, moving beyond the idea of treating cancer as just an unchanging disease to a personalized medicine and how to best approach that. Obviously, personalized medicine comes with its own complications and challenges, everything from the cost of producing these drugs that are used for a smaller and smaller niche group of patients to how to recognize when a patient has a particular tumor with a unique characteristic that will allow the efficacy of one of these treatments. So there are obviously many, many challenges, and research is trying to push the boundary of that. So it's always a give and take process. I'm going to do kind of a brief view on the treatment of cancer. My lab tends to look at the late stage, the metastatic and the castration-resistant prostate cancer specifically. When prostate cancer does arise and is first diagnosed in the clinic, by and large, many of these cancers are localized to the prostate. There are some that are metastatic at diagnosis. When the first patient first comes in, the cancer has already spread beyond the prostatic organ. In patients with localized prostate cancer, surgery or radiation are the main approaches to treatment currently. And by and large, they have a fairly reasonable success rate in driving the cancer into remission or removing it completely, as far as clinicians can tell. Unfortunately, there are some cancers that do recur and return, at which point they're often characterized as metastatic. Whether it's a local recurrence or recurrence elsewhere in the body, the cancer is returned after initial treatment. At this point, one of the standard of cares is deprivation of androgens. Prostate cancer cells, by and large, are initially dependent on testosterone and other androgen hormones to proliferate and grow. So the theory follows that by depleting the body's testosterone, you can limit the growth of these malignant cells. This is kind of a standard approach that's been been one of the options for many, many years. Unfortunately, some cancers do progress to the point where they are no longer resistant to this, and they are termed metastatic and castrate resistant, at which point you begin exploring all the different therapies that have been discussed. Docetaxel and cabazitaxel are often used in this setting. They were referenced earlier by Frank, but there are many other options. Abiraterone and enzalutamide are two of the most commonly used androgen receptor antagonists. There are also immunotherapies, which try and spur the body's innate immune system to better deal with the cancer. There are PARP inhibitors. This is one that I've done a lot of work on myself recently, a relatively cheap drug that is being reused to target patients and tumors where the tumor's ability to repair DNA is particularly compromised. So they require even more mutations than normal, and PARP inhibitors are particularly effective for those tumors. And then there are many, many other therapeutics being developed, being reused. And one of the underlying principles of this, obviously, there are many companies at work developing new treatments, and for better or worse, these can often be very expensive, especially when they're first put on the market. But there are also many, many labs working to take existing drugs that are long past the expiration of their patent and try and reuse them in a new setting. I'm trying to figure out how they're best used, which is a much more cost-effective approach and results in a much cheaper medication. So there are many different umbrellas here that are overlapping and offering new options with every passing year. Important to note what a biomarker is. So it's a term that's thrown around a lot in cancer research. Basically, it's some kind of biological molecule, be it protein, be it DNA, be it something else, that's found in the blood or a bodily fluid that can inform on how a patient might respond to a treatment or how a patient's disease is progressing. An example of this is really well known, I think, is PSA. Prostate-specific antigen. It is a useful marker that can be detected in the blood as a way of initially screening and diagnosing prostate cancer, as well as observing its potential reoccurrence down the road of treatment. So that's one that's very well known, and so many researchers are constantly working to characterize new biomarkers to figure out which cancers may respond to which disease. By and large, biomarkers help determine which therapy to give a patient and when treatment can be optimized. Where do these biomarkers come from? Like I said, they can be used for everything from blood to different, perhaps like a biopsy tissue. It's important to note though, and remember, the research my lab does is very much in the late stage of prostate cancer, at which point that initial diagnostic biopsy performed potentially years before when the patient first came to clinic is often no longer reflective of the current tumor's mutational profile, their mutational landscape. The cancer is constantly growing and changing over time, especially as it's hit with waves and waves of new therapy and it's adapting to them. So there is a need for a more up-to-date biomarker. Metastatic tissue biopsies are generally not performed in prostate cancer. They're more rare due to the difficulty of taking a biopsy from a cancer that often spreads to bone. One thing our lab is really pioneered and driven, and this is kind of what my professor is a key opinion leader on right now, is the idea of plasma cell-free DNA. It is a minimally invasive option to sample DNA present in the blood. So how does this work exactly? Well, all cells, when they die, whether naturally or unnaturally, release DNA into the blood. Now, these are not the long, clean strands that are normally within the cell. These are like highly shredded fragments of DNA, as if the entire ingredient book has been run through the paper shredder and dumped out into the aether. And all cells do this, normal cells, cancer cells, all of them. However, we observed that there is increased amounts of cell-free DNA, cfDNA, observed in patients with cancer versus those that do not have cancer. And what we've come to realize is that a portion of the cell-free DNA is what we call circulating tumor DNA. Of all the cell-free DNA fragments we can detect in the blood, what fraction of them come from malignant tumor cells? This is the ctDNA. And this is often given as a fraction. So when we sample a patient's blood, is 1% of it from the tumor or up to 50% of the fragments we observe from the tumor? And that's how we go about detecting this DNA. What do we do with it? Well, our lab is a next generation sequencing lab. So we perform DNA sequencing on these fragmented DNA pieces to infer different mutations present in the tumor. And again, this is a really great approach because with a simple blood draw that can be performed by any nurse in any clinic rather than need for a surgeon trained to perform bone biopsies is much less invasive and much easier to do and can be done very quickly for longitudinal review over time, which I'll kind of get back to in a sec. So we can infer and get an idea as to what mutations are present in each individual patient in real time, which is an incredibly valuable resource when trying to figure out what treatments are most optimal and will have the least negative side effects for each case. And the important thing to note is when this technology is most useful. You'll see here in this figure, patients that have what we would say the best prognosis, the lowest rate of tumor proliferation, very low cell turnover, not really detectable lesions by imaging, are also the patients that are going to have the least amount of tumor DNA. There's a very clear correlation between large amounts of growing tumor that is turning over and a large amount of DNA being shed into the blood by that tumor. So patients that are in the very late stage of this aggressive, poor prognosis disease are those that are going to have a very, very high what we would call ctDNA fraction. And we've seen patients where when we sample the blood, up to 80 or 90% of the DNA fragments are tumor derived. So in these patients, this is when this technology is actually most optimal, which is further useful because these are patients who are probably not going to be amenable and healthy enough to undergo a very invasive bone biopsy. This is a great way to offer an alternative to continue to study and keep up on that cancer for patients that really can't undergo a bone biopsy at that point. This is a quick slide on just the kind of proof of concept and validation. By and large in the past, it's the tissue biopsies that were the standard of care, the gold standard for how to go about profiling a tumor. So you need to show that what we're seeing in these tiny DNA fragments is actually representative of the cancer. So if you look in this plot here on the left, this rainbow bar plot, on the top half of the plot, you're looking at tumor, a solid tumor biopsies. And the bottom, you're looking at what we call these liquid biopsies, blood-based analyses looking at the fragmented DNA. Every single bar is a unique patient. The colors indicate the different patient cases we were examining, and the height indicates the frequency at which we believe the mutation is present in tumor cells. And the important thing to take away is, by and large, every single mutation detected in a solid tumor biopsy, the standard of care, is also seen in the liquid biopsy equivalents taken at the same time. Obviously, there are differences in frequency, and that's everything from machine artifacts to just differences of sampling. But by and large, it's good to see that every mutation we observe is detected in both. On the right, you kind of see a similar thing. These are looking at two distinct profiles. On the left is the androgen receptor, one gene. On the right is BRCA2, another gene. And essentially, we're plotting here the correlation between liquid and solid mutation frequency again, and showing a fairly strong correlation between the two. Again, a proof of concept that what we're seeing here is in fact true. A necessary step in using this technology.
That's really
important thing. Please jump in. Sorry, is there a question?
Yeah, I said that's really good news that the liquid biopsy and the tissue biopsy have such a great correlation.
They really do. It's there is one thing that confounds it, of course, is when you take a specific biopsy from like a metastatic region, that's only going to be reflective of cells that are in that area. So if you have multiple metastatic lesions that have become very genetically distinct, there's going to be a lot more discordance than a blood-based sample, which is sampling every cell in the body at once, right? Every tumor, every cell that's contributing DNA is going to be detected there in some capacity. So you're getting more of like a total body scan as compared to like a hyper-focused look at one region. So that has its own strengths and weaknesses. You can get an idea of what's going on exactly, but necessarily not the specifics of a given lesion. So there are strengths and weaknesses.
So did your work with the people in Belgium help that decision?
Very much so, and I'll come back to that at the end.
Okay.
What we're doing, but I think I do have a slide on it. But a quick on that idea on that. One project we've taken right now is with a group in Belgium, and what we've done is in those cases they after doing the radical prostatectomy, they took many biopsies, upwards of 10 or so, of the surgically removed prostate as a way of inferring like how many of the initial biopsies are needed to infer on the late stage. Many cases, like only a few are done. Is one biopsy going to be representative? 2, 3, and how does that compare to this concept of cell-free DNA in the late stage setting and the overlap in profiles between the two? And so you've been seeing some pretty interesting research coming out of that. We're hoping to move forward with manuscript writing in the coming year, but it's been really cool.
Good. Thank you.
No worries. And one thing I was kind of getting at earlier is that, and I think many people are I'm sure you're already kind of catching on to this, if there is an association between the amount of tumor DNA that we detect and how much proliferation the tumor is experiencing, that in and of itself is not ctDNA fraction, the amount of tumor DNA we detect when we take a blood sample, is that not of itself indicative of tumor burden and as a biomarker for clinical aggression? And you would be exactly right if you were wondering that. And in these plots here, these are what we call Kaplan-Meier plots. They're a measure of in a cohort of patients' survival over many years. So this one here on the right, in a cohort of 200 patients that I've worked with, the line here, the most steep line in dark red, is the patients who are experiencing the highest mortality rate over time. And these are patients who also had the highest detected burden of circulating tumor DNA in the range of 30 to upwards of almost 100% of the tumor DNA fragments where the DNA fragments in the blood were from tumor. This middle pink line, the patients that have a more moderate mortality were those that had a much lower burden of tumor DNA, down between 2 and 30%. And by and large, those patients who did the best on treatment were those that had no detectable ctDNA. Whenever we took a sample, as far as we could tell, every DNA fragment was from a normal benign cell, not a tumor cell. And in a much smaller cohort over here, this is less than 100 patients, you again see the same trend, such to the point that over 36 months, those patients that had no detectable ctDNA, not one of them passed away in those 3 years. So again, a hallmark of if you cannot detect ctDNA, that means that probably the tumor is not turning over very much, which is itself an indication that it's not at a particularly aggressive stage right now. And these results were published a few years back at some major conferences, and then we're taking this research and expanding it and looking deeper into it right now. From a genomic point of view, this is kind of where my lab kind of steps back in on the other side from the clinical. I'm looking at given mutations. Before we mentioned genes like P53, BRCA2, and these can be markers of possible opportunities for unique and personalized treatment. But one of the advantages of ctDNA is that we can also look at different mutations and alterations over time. So right now here, we're just looking at the level of cell-free DNA again, but in two very different cases. In one case here, a patient is being treated with a new specific medication. It might be a chemotherapy that they thought was useful. It might be some other therapy. But at each point here, another blood draw is taken. For an unclear, these might be 6 months apart or they might be a year apart. But at every point, as far as we can tell, the level of cell-free DNA is rising. And this is indicating that the tumor is likely not responding to that therapy. It's having no effect, at which point it's unnecessary to be administering the medication because of all the side effects associated when it's not having any real benefit. This is contrasted by the case on the right, where the first cell-free DNA sample taken after the initiation of treatment, there was nothing detected, which indicated that at least at that moment, there was no detectable tumor, and the medication had a severe effect on the tumor's growth, which is exactly what you want to see. It's indicative of benefit, and this treatment should continue for this patient. If at some point down the road, you then saw a spike as the tumor began to increase, that might be indicative that, okay, this treatment is no longer working. Let's stop it and move on to the next option, not keep using a drug that's no longer effective. So it's one of the great advantages of this blood draw, because you can do it so quickly and constantly keep up on the tumor's current state. Here we're getting now into the specifics of actual mutations, these biomarkers of response. P53 is one that I mentioned before, as one that lots of people discuss in the field. In prostate cancer, it's associated with aggressive disease and progression to late-stage disease. And here we're quickly just looking at another one of these survival plots. Again, looking at the gray here is patients that had no quantifiable ctDNA, and then it's a measure of how whether or not the P53 mutation was detected in these cases. So blue is no mutation was detected, pink is that one copy was detected, and red is that actually 2 mutations to the same gene were detected, so compounding hits. And with each increase, you see a lower survival rate overall, indicative of the unfortunate effects of harboring a P53 mutation in a tumor. These patients were receiving abiraterone or enzalutamide, standard of care treatments in the late stage setting. And this is an example, unfortunately, P53 is not really an actionable alteration. It's an indicator of aggressiveness, and it's a sign that it's very useful to keep a very close eye on that cancer, because it will likely progress quite quickly through a lot of treatments, but there is no option currently for a drug to exploit that. This is contrasted, however, by BRCA2. I mentioned it before, BRCA1 and BRCA2 are responsible for repairing mutations in the DNA, specifically what we call double-stranded breaks through a process known as, and you'll forgive some jargon here, homologous recombination repair. But we frequently see loss of the function of BRCA2 in many cancers. Breast cancer was first characterized, but like I said, also ovarian and prostate. However, unlike TP53, tumors that have loss of BRCA2 are often quite sensitive to some therapeutic options, particularly here, treatment with a platinum-based chemotherapy, or as other drug I mentioned, a PARP inhibitor. And both of them exploit a weakness of these tumors because their ability to repair DNA is compromised beyond normal. And what you're looking at here is a particular case that we've worked with where, and you're looking at the x-rays, these are the tumor lesions in the pelvic area. I believe this is the pelvic area. And when you observe later, there is a drastic reduction in treatment of these cases. It's important to note this is a patient that I was working with who had working with their data on helping their clinician. And this patient had neuroendocrine prostate cancer, so a rare subtype of particularly aggressive cancer that does not respond well to most treatments. But upon realizing that their tumor had a defective copy of BRCA2, we the clinician used platinum chemotherapy in this case and observed a drastic and very long sustained response to this treatment. And despite having an expected survival of less than a year, this patient remained on platinum for more than 3 years, a drug that nobody would have thought to use otherwise because he had already received chemotherapy at this point. No one thought to administer it again until this finding came to light. And this patient experienced a very long and durable response on this therapy. And it's kind of exactly showing the use of this technology, because platinum chemotherapy is also relatively cheap as far as the plethora of drugs available. It's not going to be nearly as expensive as some of these more experimental immunotherapies and exploitative therapies. So it's a perfect example of how this technology identified an alteration that could then be used to target that tumor with a drug that would have a specific benefit to them. And as a result, the patient had a far and above amazing response and a durable response beyond what was expected, which is incredibly rewarding and exciting to see.
Yeah.
And I believe I've not been this the clinician who works with him now. I no longer work with him closely, but I believe that after platinum ceased to work, they went on treatment with PARP inhibition and are still responding to the PARP inhibitor to this day. And this paper we published in 2016, so this is now going on 5 years later, more than 4 years after their expected prognosis, which is incredibly inspiring. And this is kind of showing what is the use of this kit. It's kind of like here in the last slide or two, we're synthesizing a lot of ideas. What this technology allows, the sampling of DNA from a simple blood draw, is identifying these mutations and checking on them regularly over time. And here's kind of a case I want to walk you through. This is a more theoretical case. A patient with a germline BRCA2 mutation is detected. This inhibits the function of BRCA2 in that tumor. They initially have a great response to a PARP inhibitor. Kind of like the previous patient, this drug causes tumor cell death when the cell cannot repair DNA. And they've, however, after about 6 months on treatment, they developed progressive disease again, as indicated. We observed through a circulating tumor or a cell-free biopsy. And what we observed is that there was a reversion mutation. The cancer turned the function of BRCA2 back on. It corrected its original alteration and was no longer responding to PARP inhibitors. So while there was a short and powerful response, ultimately it did not work in the long term. But now you can identify that and immediately move on to a new line of therapy and not administer PARP inhibition with unnecessary side effects. So that's again the advantage, the multiple overlapping advantages of this technology. One last thing I'll talk about here, the presence of circulating tumor DNA in cancer. It's particularly abundant in patients that have de novo metastatic disease. This is the subset of patients that when they first arrive at the clinic, the cancer is already metastatic. And it's a particularly aggressive subset that often have poor prognosis. But what we're observing is that circulating tumor DNA is much higher in these patients than the patients that come in with localized cancer. So there's a lot of hope that using their DNA in these samples can inform on this unique status. And this is exactly the purpose of our collaboration with the team in Belgium. All the patients we're looking at were patients with de novo metastatic disease, disease that's already spread to the body when they first arrived at clinic. And that's the group that we're trying to work with and help there. Kind of the point to leave you with at the very end, a lot of the work we're doing is correlative. We're observing trends and drawing correlations, but by and large, if you want to inform on a real change in standard of care practice, they need to be prospective. You need to design a trial where we use this technology, this liquid biopsy, this blood draw to look at DNA, and then use that to group patients based on possible treatments for them and observe how well that works. It has to be prospective. Retrospective analysis, looking back on previous cases, is only so useful. So one thing I'm sure you guys have heard about is the ongoing umbrella trial with my mentor and his colleague, Dr. Kim Chi, where we're using at time of diagnosis or later in disease progression, a cell-free DNA sample. It's sent to our lab where DNA is extracted and analyzed and computationally reviewed. This goes back to a team of clinicians and researchers who can then assign the patients to different treatment arms, they're calling it, of the study based on specific alterations detected in their tumor. And this is kind of like what I consider like the standard core of personalized medicine, building different trials that have like specific treatments for each unique tumor. And every year, more of these trials are being, more of these trial arms are being opened. I think at this point, this figure itself is already out of date because they've opened some new ones in the past 12 months. So it's really exciting to see. And this trial is ongoing right now. I think that's the end of the primary talk I gave. Happy to answer any questions you have. Two anecdotes I wanted to leave you with. Unfortunately, I didn't have time to fit them into these slides here. I mentioned briefly about the project with Belgium. One project I'm leading coming into next year in collaboration with the Dana Farber Cancer Institute, which is the Cancer Institute at Harvard. I applied for a grant to fund a project with them, and it was granted by the UBC to look at, in these cases of BRCA2 and defective DNA repair, which is already a great opportunity for a unique personalized treatment. How do we look now, instead of at the DNA level, let's go a level higher. Let's look at the epigenetic level, which is regulating the DNA beyond mutations. And the hope is that even patients that don't have, say, a mutation in BRCA2, but through some other complex mechanism have perturbed the gene's function, we can now capture even a larger umbrella of patients that would respond well to these therapies that are just being missed by the current technology right now. So we're going to be using these liquid biopsies and analyzing their epigenetic methylation status, is what we're looking for, to try and expand the umbrella of possible patients. So that's coming up down the road. We're currently set to, I'll be traveling to Boston, COVID pending, in June of next year to begin this particular project. So some very exciting stuff coming up. But yep, that's all I have to say. Thank you very much for listening. And please, any questions, I'd be more than happy to answer them.
Questions, anybody? I'll start off with one question, and I think you answered this question. I think is, what impact will it have on newly diagnosed patients down the road? What are the possibilities?
Well, ideally, down the road, what we see emerging, this would be the dream, is that patients, when they're initially screened, they look for specific alterations in the diagnostic biopsy potentially. And if they identify any of them, they can immediately proceed on to unique customized arms with a line of treatments ready to go for them. This will work for a lot of patients, and then those that do relapse are immediately, these liquid biopsies are utilized to provide very fast and real-time updates so that they get the treatment for them as fast and as specific as possible. And it's just all about, I think this was mentioned earlier by Frank, the idea that you have these overlapping, potentially cyclical patterns of treatments that can be used over time. And so just the faster and more accurate data you can have at each stage, the better informed you can make for the drug, and hopefully continue to use these treatments longer than you could normally. That's the idea I see.
Any other questions from anybody? Don, Nico?
Hi, yep. Hi, Evan. This is Don. I've been on active surveillance for 10 years. I have had no treatment. Is there any advantage for me to get the BCRA to test to determine?
That's a really good question. And I do know that this is an area kind of parallel to my research, is using this technology, the blood-based biopsy, to look for what they call MRD, minimal residual disease after treatment, or localized or metastatic recurrence later on. And the idea that they're using like hypersensitive analyses to look for the emergence of any tumor cells in patients that have either been in remission for a very long time. I'm not sure personally where that is at these days. I would definitely speak to your clinician. They would know much more about the specifics of that to me, but I know there's a lot of research going into it right now. And when I was in Miami in January, there was a conference on that specifically, the advances in the liquid biopsy. And a lot of the talk for the first time in a few years was on this idea of minimal residual disease detection. So there's a lot of great research in that area. I do not know where it's at, like at the moment, with regards to actual practice in the clinical setting. So, but it's something to bring up with your clinician for sure, if there are any options there.
Okay, thank you.
No worries.
Any other questions?
Yeah, I have a question. This is Norm. And I don't think I understood your response to Lynn entirely, Lynn's question. And that is simply, are patients free to ask for a liquid biopsy as part of their treatment plan when they have metastatic cancer, or is this still at the trial stage? Stop right there.
Well, I will comment first and foremost that given that my work with the academic lab, how informed I am on the actual clinical practices is limited. I'm getting it through a couple filters information. So please don't take anything I say as standard of care. But beyond that, from what I have worked with, I know that there are a lot of tests emerging that where a company has designed a much more robust and standardized approach to these tests. There's the Garden 360, there's the Foundation. These companies have a standardized approach to looking at these cases. And these are tests that can be ordered by any clinician as far as I'm aware. As far as I believe, they can be ordered by anybody. There are strengths and limitations of these tests. I know they just released the newest version of them this year, which have corrected a lot of the problems before. And it's different comparing a company-based test to what we're doing here, which is more of an academic setting for clinical trials, which comes with its own like personalized backing and funding of government grants. It's compared to a company trying to build one that's standard for each case. So I believe those can be ordered and they can inform on some possibilities. What I'm talking about here is more in the trial setting, but I believe there is both.
Okay, thank you.
No worries.
Anybody else? Can I make a comment then, Evan? I like to use the word remission. I happen to have a different philosophy from many people. Once you have prostate cancer, I don't think it's curable, but it is by the treatments we follow, it can be put in remission, and we do an absolutely marvelous job in doing that with the clinicians that we have, and some are very, very successful. The other one is the mutations. I'm absolutely spellbounded by the amount of mutations that occur. And I understand that only 6 cancers so far have been identified, prostate cancer that is. There may be others that I don't know about. But I understand a paper that I read, there were 6 identified cancers some time ago, but there may be more now. But that may be because of mutations, I'm not sure.
Sorry, what do you mean on that last point with regards to there are 6 different unique types of prostate cancer?
Yeah, 6 different types of prostate cancer.
I've not actually heard of that particular characterization. The number here thrown around a lot is the idea between classic adenocarcinoma and the more small cell neuroendocrine disease. That's one that's been characterized since the beginning. Even just the cells themselves look different. And I know they're creating further definitions of cell tumors based on, like you said, their mutational profile. I'm not familiar with this 6 number category myself, and I'm sure that however they characterize it is probably expanded because of new findings in the mutational profiles of different tumors. So it is constantly upgoing.
There was a paper from England.
Okay.
Anyway, the mutations probably take care of that anyway, because a different cancer is a result of mutation. And is there any indication on when the mutations are likely to occur, or under what circumstances, that kind of thing?
Definitely. So there is a lot of research going on that in the early stage. Obviously, there's exposure to like the more well-known carcinogens, like UV, constant like sunburns over many years have a much high increased risk of melanoma. Smoking increases risk of lung and bladder cancer, and these are done like years before the emergence of any cancer. There is also less evidence on like more subtle characteristics, like those with careers or lifestyles that come with a high amount of associated stress puts a lot of stress itself on the body and the cell's growth. And this is actually, as far as I'm aware, can lead to a rise of mutations in cells over time. And there's so many things that can cause this. There's so many different factors, and it's ongoing from the moment you're born all the way up to the latest stages of cancer treatment. There's always an opportunity to acquire more mutations. It never stops.
Yeah. Okay, thank you. Any other questions for Evan? Oh, the other question I was going to ask you, how did you get an interest in research in prostate cancer? What led you to this? Diversion.
Oh, for sure. My interest in this actually came from the mentor I first met. I was the first student my mentor ever hired. He was a young, passionate 35-year-old doctor, newly appointed to the thing, had honestly really no idea what he was doing, just took some incredible ideas and a lot of work ethic to research them. And I started with him about 6 years ago now. I started as a co-op student, and I honestly knew very little about the disease before. I mean, my grandfather had prostate cancer when I was very young, but he was one of the very exceptionally lucky cases where he, after treatment with a surgical removal, has been in remission ever since, for I guess going on almost 18 years now. So he's a very fortunate case. So I had a little bit of it, and I only remembered the from a very young age and didn't have much with it growing up. But when I had the opportunity to work with this professor, kind of like was incredibly inspired by his enthusiasm and fervor for this research. Kind of like you, Len, he's looked at thousands of mutational profiles at this point, and yet every time he opens a new one, he gets this like little giddy excitement, like, oh, there's one of these, and oh, there's one of these. He's so interested by what's going on in these tumors and their complexity and the mutational changes that are unique to every single case. I was very inspired by that and decided to come along with him for the long haul, and working for 7 years since.
Wow.
For me, if I may follow up, for me, what I've realized has actually been a personal revelation in the last 6 or 7 months after returning from Belgium, is that while I do love prostate cancer research, this is actually what I enjoy more. I really like talking with people about it. The day-to-day grind of writing thousands of lines of computer code is not what I'm as good at. And so my actual plan right now, starting next year, is to go back to school for medicine. So that's my plan, is to take the research I've learned and bring it back to a more patient-centric thing. That's honestly what I love. This kind of talking stuff and discussing disease cases is something I want to be able to do better. And right now I only know the academic side, and I want to be able to bring the medical side too, because that's what I find inspiring.
And are you a Vancouverite?
Yes, well, Maple Ridge, born and raised, but I moved to Vancouver for UBC.
Yeah. Well, that's Vancouver.
Close
well,
enough.
we like to think so anyway. We're part of Vancouver.
I've got another question, Len, for
Sure.
Evan.
Go ahead, Norton.
Yes.
And I'll go back to one of your early initial slides, and you mentioned 3 possible sources of mutations. And which of the 3 is the most frequent cause or associated with the development of prostate cancer? Heredity, radiation, or spontaneous errors?
Which is the most frequent?
Frequent, yeah, source of prostate cancer, do you think?
Prostate cancer, among other cancers, is a trend toward the germline mutations. It's one of the cancers that are known to have a high degree of heritable mutations, and joins the ranks of breast and ovarian and a few others among that. Other cancers like melanoma, very rarely characterized with germline, is more about the acquired somatic mutations from sunlight exposure over time. So that's a big one in prostate cancer. And honestly, up until the last few years, nobody actually really cared about the somatic mutations. It's been a large, heavy push from my lab and other labs to try and say, no, these mutations have a role too. They are important. So by and large, to answer your question, germline, the hereditary ones, for a long period of time. But nowadays, I would say there's a push for the second one. Spontaneous errors during replication. The exposure to radiation, carcinogens, as far as I know, not a big component of prostate cancer. I mean, the lungs are awash with smoke every time you smoke. The bladder is awash with urea, and all the carcinogens are released into the system over time. So these ones are much more exposed to those. Prostate cancer, less so. I mean, there are obviously links with diet that are in prostate being characterized, but it's not as big.
Have you been able to notice a difference in how the ctDNA information helps in the treatment of hereditary-based cancers versus spontaneous error cancers? Is one more amenable to treatment using this technology than the other?
No is the answer. That's the flat answer. It more depends on which alteration is detected as compared to in what capacity is it germline or somatic. I mean, there are tangential advantages. For example, a standard of care for men with localized prostate cancer is not a sequencing of DNA. That's not what's really done right now. Right. But when this test is performed, if the mutation is germline, so it's present in every cell, let's say it's in a gene like BRCA2, which is known to have a associated with aggressive disease, not only does that help the patient itself, but informs on potential screening for many of that patient's associated family members because it's hereditary. And there's an advantage of that that's tangential to disease-specific treatment itself. The advantage of somatic testing is that you will never detect somatic mutations unless you capture the tumor itself. So if the disease has spread and it's metastatic, no tissue biopsy, unless you capture the actual region that has the mutation itself, is going to inform on those alterations and lend insight to specific treatment. Whereas a ctDNA test, like I said, it captures every bit of a DNA in the blood, or samples, I should say, every bit of DNA in the blood, has a much higher capacity to inform on those somatically acquired mutations. So
Okay.
no, but there are differences on each side.
Good, thank you.
Questions? Anybody else? Any other questions? I have one more.
Sure.
Small cell cancers.
Mhm.
I understand that that's aggressive stuff, and currently we have limited treatments for it.
Yes.
Simple
I mean,
answer.
well, sorry, you might want to expand your question. The case that I shared about the incredible remission was one of those small cell cases, and thankfully the alteration that we detected.
Really?
Yes, that was a small cell case. So he had a late stage neuroendocrine disease, so small cell cancer. And those cancers will not respond to any like standard of care treatment, abiraterone, enzalutamide. They don't work because the cancer essentially is not dependent on the androgen receptor at all. In most prostate cancer cells, even when you deplete testosterone, what the cancer has done is just become hypersensitive. So the fact that even if you have 1% of your normal testosterone, the cancer is fine with that. So that's why they say it's castration resistant. It's still flourishing despite an incredible drop in circulating androgen hormones. Neuroendocrine cells are different. They've basically like turned off the need for testosterone at all. So no amount of treating that pathway, that axis, as we call it, will do anything. So you've just kind of like ruled out like half of the armamentarium of drugs available. That being said, unique cases like this where we detect specific alterations, you can still use treatments like PARP inhibitors and they will still work in the exact same capacity. And this patient actually had a very sustained response despite a very poor prognosis on an extremely aggressive subtype.
So what percentage of the patients are you aware that have this small cell cancer?
Oh, I know it's increasing. Ballpark, I would say it's in the low 10%, 10 to 15% of cases. Some cancers develop it over time. As you continue to like hammer at this pathway over and over and over, some cancers will slowly move toward a neuroendocrine small cell phenotype, and some just when diagnosed are like that. That's a much lower fraction. So it's hard to give a number because they rise differently and some come up at the beginning, but it's a small group. I would say less than 10%. But over time, as we're getting better and better at treating standard prostate cancer, you do see more cases shifting to this hyper-aggressive state.
So it looks like the more that we know about the early stages of the kind of cancer we have, the better we are at understanding where we're going.
Exactly. And cases beforehand that would have been had a very low prognosis, 20 years ago, with all the lines of therapeutic options we have now, we keep pushing past a boundary that we never would have expected before, and which is why we see an emergence of more aggressive disease. It's just kind of a side benefit of doing a better job.
It's absolutely marvelous what you guys are doing for us guys. And it's really encouraging for those who have not yet joined the club, that we have some very, very good stuff for them. I know we've had a couple of calls from people a bit worried about where they're going on their journey, and I just have to reassure them, you're in Vancouver and you have one of the best opportunities here to be treated with the very latest stuff that's available to you. So don't be worried, you'll be treated well.
Yeah, Kimchi's work with the BC Cancer Organization and like Vancouver and the Lower Mainland and BC as a whole is, especially in this field in prostate cancer, is among the leading researchers in the world right now, which is, I mean, incredibly inspiring for me to be a part of, but also just incredibly rewarding to be a part of this system, especially compared to some of our neighbors down south who have a little bit more rough go of it. BC is a beacon of light in prostate cancer treatment.
Thank you. I was trying to say, I often say that, but I'm not sure I get the message across. But it's really good to hear from somebody who's on the inside.
Especially when we're comparing against researchers working in the great centers of the world, like Harvard and Oxford, that like UBC and BC's treatment of prostate cancer like rivals and is shared in the same platform as these other incredible institutions is, amazing.
That's really, really great, good news. Great to hear. If there are other questions, I want to say thank you on behalf of us. That it's been a marvelous, and I've enjoyed your message to us. Thank you again,
very much,
Evan. It's very much appreciated. And before you get into your new studies, maybe we can have you back.
I would love to. Yeah, please let me know anytime. I'm happy to join.
Okay, and maybe on emergency cases.
The advantage of being a student is that we have a much quicker turnaround than some of the professors whose schedules are locked in for the next month. So.